you hear me?
Oh, yes.
Awesome. Well, I'm so excited to be here. As Dr. P says, we've known each other for a decade, which is so weird to me. I don't know where the time has gone, but I love Boise State. I love working with students, and most of my clients right now are unfortunately 9 to 12 years old, probably about 50% of them, but I have quite a few Boise State students as well. And usually if I get a referral from a Boise State student, I do what I can to work with them, because I really do love working with students, and I think it's just such an exciting and fun time of life. And so pretty much Dr. P, shared most of what I do. I specialize in DBT therapy. It's a therapy that is evidence-based, is the gold standard for treating personality disorders, and is now in the process of becoming evidence-based for eating disorders, particularly binge eating disorder. And I also specialize in RODBT, and it's a type of therapy that is used for over-controlled patients, so more so like anorexia nervosa and OCD. So I work a lot with athletes. In my experience as an athlete and just in the realm of eating disorders, and every single one of my clients actually has an eating disorder. And then I also kind of offshoot into personality disorders with adults, and then suicide prevention with teens. I'm really trying not to work with adults anymore because there aren't any. There's only one other therapist in the Valley that treats teens with eating disorders, and so because there's other therapists that do specialize in adults, I'm trying to just only focus on treating 18 and under. And yeah, unfortunately, a lot of really young kids coming my way right now. And so lots of 9-year-olds, which has really kind of transitioned into the type of work that I do. I'm not trained in play therapy. I don't do play therapy. And yet I've had to really kind of change DBT therapy to be a little bit more child oriented. A lot of dog analogies and a lot of crafts I've been doing lately. So I am certified in eating disorders, so I was certified through the International Association of Eating Disorder Professionals. It took about 3-4 years to get that certification. It's technically a board certification. The designation is given to medical doctors, therapists, dietitians, and physical therapists. So it's a pretty rigorous training that was after graduate school, just in treating eating disorders. And so that training, I do recommend if you do want to become a therapist, I do recommend getting specialized just so you have that extra training in whatever it is you're doing, whether that's trauma therapy, kids, play therapy, eating disorders, OCD, etc. So yeah, I just kind of want to open the time up to you. I can explain more a little bit about my process. I'm really just here to support you and whatever questions you have. So let me have it. I'm all ears. Yeah.
Can you explain more about DBT? Because I have a cousin who has narcissistic personality disorder and bipolar. Bipolar, I'm not sure, but can you explain the process?
Yes. So DBT therapy, it's an 18-month intensive psychotherapy. It includes, so there's fidelity to the model and then non-fidelity to the model. Unfortunately, I'm one of the only DBT therapists in the state right now, so I can't really practice DBT in fidelity to the model. So it was a therapy that comes from University of Washington. Dr. Marsha Linehan in 1993 created this therapy for personality disorder. So she actually has a personality disorder herself and was working in a female prison right out of grad school, gets her PhD, and there's person-centered therapy, which I'm sure a lot of you have heard about in like intro to counseling. Person-centered therapy is very much like, I'm here for you, I'm just supporting you, accept, validate, which is really great and wonderful for people that want process-oriented therapy and just want to kind of explore more about their lives. But for somebody that's incredibly suicidal, it's not a good fit. They need boundaries, they need structure. And so at that time, there was process-oriented therapy, person-centered, and then behaviorism, which was very like intense, just like John Watson, Pavlov, like you do this, you don't get this, or reinforcements, punishments, etc. So she's working in a female prison with a bunch of suicidal women, and goes in day one and is like, I'm just going to accept, no matter what, I'm just going to accept these people, and I'm just going to love them and give them care and unconditional positive regard. And what she found is that they were actually more suicidal with that, and that they were having more suicide attempts because there was no behavior change. So her having borderline personality disorder, which is very black and white, back and forth, goes to, okay, now I'm going to be this like really like tough behaviorist, and I'm going to only push them to change, and I'm only going to do reinforcements and punishments and rewards. And what she found is that they were actually continuing to be more suicidal, and it was actually failing. And so then she finds, okay, well, maybe I need to do both. Maybe I need to accept them and push them to change. And so that's where she created DBT. It's this highly skills focused therapy that is really like, how can we get you into your window of tolerance? So how can I help you cope with things? Let me teach you all of these skills, and I'm going to accept you and validate you. And so DBT is a therapy of two opposing sides that can also be true at once, and utilizing skills to reduce suffering. So it's really, really beautiful. It's incredibly helpful for borderline personality disorder. In fact, when I was a grad student, I interned for a year and a half at a IOP, intensive outpatient for personality disorders, and we did DBT infidelity to the model, which means you meet with a patient every week for 60 minutes. They do a 2-hour DBT group, which is just a class teaching them skills. And then you also utilize phone coaching, which means you can just help them with skills in the moment. And it was incredibly efficacious. And so I love DBT. It's really helpful for teens too, because they often don't want to just come in and like talk about their dreams and their future and their past and whatever. So they come in and they get to learn skills. So they feel like they're building mastery, and they feel like they are making some changes. And so it's very concrete. Like they can come in, they can learn a skill, and they feel like they're making progress. So it's really great. Kind of a tangent. This has nothing to do with grad school, but narcissistic personality disorder is an egosyntonic disorder, similar in some ways to anorexia nervosa. They're actually the only two disorders that are egosyntonic, meaning that the person that is suffering often doesn't think they have a problem and often doesn't want to change. And so it's really, really tough to do therapy with egosyntonic disorders, because most of the time those people don't show up in therapy. And so eating disorders, you have a little bit more leverage and buy-in because it is so behavioral. Narcissistic personality disorders are really tough to treat. So gosh, total side rant, but DBT is great still.
We did have a really tough time getting her in there.
Yes, definitely. Yeah. We'll start here and then we'll go this way. Yeah.
How did you decide which graduate program you wanted to go into?
Yeah, so Dr. P, I have to give her a ton of credit for this. So I really wanted to get a PhD, was like, yes, I want that shiny like PhD in clinical psych. And Dr. P was really like, just get a master's first, see what you think, see how it feels. And so I applied to some PhD programs. I ended up getting into one after I'd said yes to all the schools, and was actually really glad I didn't go forward with it at the time, and still am pretty happy with it. So as far as graduate programs, I really wanted to go to Pepperdine as well. And I was funding myself through grad school. And so got in, it was like $250K, got into this program in Washington, and it was fully funded. Like they gave me a graduate assistantship. And so it was kind of a no-brainer for me, at least, because I was I needed to fund myself, that I was like, oh, I could go $250K in debt, or I could not go into debt. So it was kind of it was not the school that I loved, and I don't really recommend it, honestly. They actually lost their accreditation, so really don't look at it anymore. But it was actually a decent school at the time, and really because I knew I wanted to specialize in eating disorders, and I had a really great mentor, Dr. Pritchard, and another mentor that's a certified specialist here in Boise. I felt like I had a good enough training and background and support outside of school to go to a program I wasn't that fond of, but I mean, that's probably like anti-academia to tell you that, but that was my experience. But there are a lot of really good programs. I think that most grad students and most like new therapists, in fact, one of my close colleagues she's a PA, she just prescribes medication. And I feel like it's very common in the field to not really learn what you expected to learn in grad school. Like I was expecting I'd go to grad school and I would like just come out, like learn, I knew everything, and that I was like really confident as a therapist. But a lot of that work actually comes in your internship. And so if you get a good internship and you have an internship that really has a strong component in the theory, so like a type of therapy, then that's really where you learn most of what you need to learn. And so one of my close colleagues that's a PA, she even went to Duke for another year after grad school just to get another year of training. And she said, like, even at Duke University, she didn't really feel prepared. It was really her internship and her mentorship and training. And so that's my biggest piece of advice for grad students. It's not necessarily what program you go to, it's who is your mentor, who's training you, and what internship are you taking. Because there's some internships out there that are pretty crummy, or internships that will just completely burn you out and have you working 60 hours a week and going to school at the same time, and that's also not healthy either. So just really finding a good program, or a good like internship program.
So I've always wanted to be a counselor, and one of my anxieties about it is like planning how you treat people. So, you know, like teachers have their curriculum. What does a counselor do? How do they plan like, what to do?
Yeah, so we create treatment plans. And so usually like second or third session with a client, you'll create a treatment plan with them, which is, you know, goals, objectives, and interventions. And so, you know, SMART goals, I'm sure you've learned in your classes before. So we'll create a big goal, which is like, I want to have food freedom, or I want to be able to heal from my eating disorder. And then we'll create intervention, or we'll create objectives to that. So, you know, client in 6 months will learn 3 DBT skills for distress tolerance and 3 DBT skills for interpersonal effectiveness or something like that. And then the intervention will be, you know, we'll meet once weekly and do DBT interpersonal effectiveness or something like that. So it's still, it's a structure, but then it's also still very loose because it is a conversation with someone and it feels very intuitive. And so usually most sessions for me are structured where they come in, we do a check-in for 15 minutes, like how's their week, what's been going on. Then we learn a skill, and then we talk about how that skill can integrate into their life for the next little bit. And so it gives me a lot of space to, you know, deal with whatever they're coming in with that week, or to deal with something deeper, but also still gives me enough structure so I know like we're doing this skill, we're going to learn this today. And so it's a loose plan. And the more that you work with people, the more that it becomes just really like intuitive. I mean, I've been doing DBT for quite a while now. So if someone comes in and they say they're dealing with this, I can pretty much pair it with the skill that we're going to connect back to.
Are you doing diagnosis of patients?
Mhm.
Okay.
Yep. Yeah. So unfortunately, to treat, to bill insurance, so I do bill insurance. I have to diagnose somebody to be reimbursed through their insurance. And so you can diagnose, and there's a bit of a split in the field where some people are like, do not pathologize people, do not diagnose. And then there's other people that are like, yes, diagnose. Yes, it is helpful to have some pathology understanding. DBT is very clinical, as in it's very like research-based, very, very like skills-based, diagnosis-based. Because oftentimes, especially with something like borderline personality disorder or anorexia, like having that diagnosis is actually pretty helpful because they're like, oh, okay, this is what's going on. There's more of a framework now. I know where to go for support. I know what skills to get. I know how I can like get more of a treatment team versus maybe somebody's just coming in with more like lifetime counseling. I might not diagnose them, but they won't get reimbursed by insurance. So it's kind of a tricky line to walk. But yes, you can diagnose with a master's degree.
What's the best way to go about finding your right internship for you when you're in grad school? Like one that's going to be like a quality experience.
Yeah, so a good university, a good program will have quality internships. So Boise State, like they have a lot of really great internships that they're paired up with, and they go through a vetting process. Eastern Washington, where I went, they have a lot of really great, in fact, I think they have phenomenal internship sites. And so they won't just pick like any willy-nilly internship site and just allow their students to go there, because they are accredited. So they have to, my program was accredited, but Boise State is accredited. So they have to go through this accreditation process with their internship sites. And so I think usually going into grad school, I think it's about 50-50 where some students are like, I want to work with anxiety, or I want to work with this population. And then the other 50% are like, oh, I don't really know what I want to do. I would recommend having at least some type of an idea so that you can get paired up with an internship site that is a fit for you. And so I was at the Ada County Jail we had like a preceptorship and a practicum, or not the Ada County Jail, at the Spokane County Jail for a little bit. And that was a good little like test for me to see if I wanted to work at the jail. And then I was at the state hospital for a little bit, which is another little bit of a test. And then I ultimately landed on the IOP clinic. But I think Boise State, the way they do it is you just pick one internship site. But if you know kind of about what you want to look for, that's going to narrow down the sites. And then I would say interview at as many as you can to find what is the best fit. And really try to find, similar to grad schools, trying to find a professor that you want to work with. So in an internship site, try to find a mentor that you want to work with. So find a therapist that you really appreciate, respect, enjoy, or if you're going to med school, if you're going to law school or whatever school you're going to, like find somebody that you want to follow and network as much as you can with them and try to follow them. That's helpful. Yeah. So Boise State, I was just looking up professors that specialize in eating disorders, found Dr. P. And I think it was my freshman year, actually. I like, walked into a room and was like, I want to study eating disorders. I want to research eating disorders. Just overly eager, like, tell me what you like. Please let me be your mentee. So I feel like I'm just pretty like humble when it comes to just being desperate and saying like, I want a mentor, I need support, I need help. So I hope Nicole doesn't mind, but Nicole kind of did the same thing to me. She was like, I wasn't even offering internships, and Nicole's like, do you have any internships? And I was like, dang it. Like I think this was in a class last year that I was speaking in. And I said this exact same thing. I was like, ask people, just get desperate. And she was like, yeah, do you have any internships? And I was like, yeah, okay, yep, you can be my intern. So I've been turned down though. I've definitely been turned down. Like my psychologist crush, Ellen Ashton Fletcher, she wrote the book on DBT for eating disorders, like legitimately. And at conferences, I like go and listen to all her talks. I like stand on the front row, I like take notes, and I'm like, hi Ellen, like, like just trying to like schmooze her. And I sat by her at a lunch one day and I was like, I would love for you to like mentor me. Is there any chance you have like availability? And she's from Chicago, just so like blunt. She's like, no, definitely not. I was like, okay, yeah, that's fine. Yep, that's okay. So you just have to be kind of humble and desperate and deal with some rejection. But I was just like looking at my interest and trying to find people that match that interest, follow their research, follow their work. And then Christy Shohet, she's the therapist that mentors me too, kind of same thing. I asked her for internship. She created an internship for me, and we actually share a wall now. So her office is right next to mine. So I can just knock on her door and ask her questions. And so I've learned so much from the two. In fact, there's so many things I say that I'm like, oh, that's such a Dr. P thing to say. Like, yes, woohoo. Like she's really imprinted on me. Or like Christy, my mentor, like there's so many things I say. I'm like, oh my gosh, like I learned that from her. But it's cool because that's how the world of like healthcare works, is you find a mentor and that is kind of like passed on. And so I think it's just too much to learn on your own. You have to have support. And especially like prior to COVID, now with COVID, like it's just too hard of a career to not have support and not to have people that have been through it and that can help you navigate this really tough world of healthcare.
How did you find your assistantship, and what was the process of that funding your education?
Yeah, so I pretty much told this school, I was like, look, I won't come here without funding. Like I got into my dream school. I was planning on going there. In fact, I had interned at a residential eating disorder facility in my undergrad program in Malibu, California. So Pepperdine was right there. Pepperdine feeds into this facility. It's called Montanito. And so I was like, Pepperdine made the most sense. I wanted to go to Pepperdine for a long time. And so pretty much told the school, I was like, yeah, I'm not going to go here without funding. And they were like, oh, okay, sure. Yeah, here you go then. So I think part of that too was like, I mean, for all of you, like you're in this class, like you probably have some pretty like good resumes. So like really having a good resume where I was like, look, I researched with Dr. P, I think for 2 years. I researched with Dr. Janucki as well. I had teaching assistantships, I had internship, and I was like, look, I've got a lot to offer. And for a grad program, like I taught a class and then I did research for them. So they want good students to come to their schools. And so really using that as leverage and saying like, hey, this is what I have to offer. Like, this is a win-win for us. And so you also kind of have to get a little desperate too and really humble. But I think, especially with programs, I mean, student debt, like a program like Pepperdine, $250K, like that's a lot of money to go into debt for, especially when we're not making like physician salaries. And so we really have to be kind of, I don't know, a little bit of a shark with it and make wise decisions there too, but also like let the schools know that. But if you're in state, it's totally different. Tuition is much different for in-state students too, which is again a bonus for Boise State. Here, I feel like I'm like plugging their program, but it is a good program. I do like Boise State's program. Yeah, but that is like, I feel like people don't talk a ton about finances. Maybe that's me being like a millennial and just being in a different generation where like, I mean, that really is something to think about, like how much you're paying in a program, how much you expect to get paid as a therapist or whatever your job is afterwards. There are some cool programs, especially in Spokane, and I think this is like the state of Washington as a whole, because my program was in Spokane, where if you work for certain agencies for 3 to 5 years after graduation, they will completely pay for your student loan, which I had a couple friends do in my cohort in grad school. So, if you worked on the reservation there, or if you worked, there was one other thing. It was actually, I think it was at the jail, then they would forgive your loans, which was pretty cool. So, yeah. Any other questions about oh yeah, go ahead.
Did you think it's difficult to do a lot of your professional training in one area and then move? Was it hard to maintain connections to have support in the field?
Yeah, so I would not have, I was only looking at schools on the West Coast where I would be interested in working. And so even though there's really great schools that do eating disorders, like Columbia University has a lot of research, UNC has a lot of great eating disorder research, it wouldn't make a ton of sense for me to go to school there and then come back and practice here in Boise. So especially in eating disorders, it's a pretty small field. It's a big field, but also a pretty small field. And so I'm actually really glad I have really good colleagues up in Spokane now, because I have a lot of clients here that will go to Gonzaga or Washington State or whatever. So I have that referral source up there. And Spokane really connected me with Seattle as well. So I have that connection. And so I have another really good friend that's in Portland, and I've done some work there with her. So I have that Pacific Northwest connection for people with eating disorders. If I was doing something more like anxiety or depression, I probably would have just tried to stay in the Valley so that I could learn all my referral sources and network with people that I would directly be working with. But I think there's 5 or 6 certified eating disorder specialists in the state of Idaho. And there's other people that specialize in eating disorders, but as far as the certified people, so it's not a massive, massive network. So having that regional network is really good. I will say though, if you are looking at going to school in California, it's really, really tough. California kind of landlocked students. So there's certain classes you have to take in California that you don't have to take in other classes or in other states. And then there's classes you have to take in other states that you don't have to take in California. California is like its own country, basically. So it's really tough to go to school in California and then come back to Boise and practice, or vice versa. And so usually, and that was another big reason why I did go to school down there, is that it was just really tough to transfer licenses, where state of Washington, I literally had to just sign a piece of paper to get an Idaho license. So Washington, Oregon, Montana, all of these Mountain West states are really, really easy to transfer. They all have reciprocity, so it's really easy to transfer licenses. I do, though, highly recommend just going to an accredited school. That is going to be a huge difference, because going to an accredited school, I just had to sign a piece of paper. If it wasn't an accredited school, I would have had to do a lot of paperwork. Yeah.
What do you specifically want to work with eating disorders?
Oh, sorry, I couldn't hear the first part of that.
What do you specifically want to work with eating disorders?
Yeah, so I had personal experience with an eating disorder. I think that most people in the eating disorder field, in fact, the treatment center I worked at, Montanito, 95% of their staff was recovered from an eating disorder. And that's, you'll find that in the field of psychology. Even most people go into something in psychology because of personal experience, because it's not a very flashy field, and it's a really tough field. So rather than going into computer science, which is I think that would be really, really tough. But I think a lot of people are oh, I'm gonna go into computer science because you can make a ton of money and work 4 hours a day or whatever. Awesome, sweet, that sounds great. Most people don't come in and do this backbreaking work because they're no, I just want to help people. Usually it's yeah, I've been through the fire and I want to be able to support people and help them understand, that recovery is possible, recovery is real. And so I think it's a high empathy field, which is also why there's high levels of burnout, but high levels of passion in this field. And so I think just the colleagues that I have are amazing, because they're all so passionate. They're so excited. And I haven't really worked in anything other than psychology. I've worked on a farm in high school. So I don't know. I didn't see that amount of passion in farming, but I'm sure maybe other fields have that passion. But there's so much passion in the world of psychology. And so I do think, though, there's a lot of like probably the number one piece of advice I would give people is to be in a place where like you are good and you are solid mentally before you go into this field. Because I think you see a lot of people that are not quite ready to go into this field, or they're not quite healed themselves, and they can do a lot of damage and a lot of harm. And so, I mean, this has to be about your clients first and your story, like 15th or 20th. So it's not, I'm not in this field because of me, I'm in this field because of my clients, but I can't like have that counter transference in sessions. And it's tough for me. Like day one, I was put in Spokane County Jail with people that were incredibly suicidal and had a lot of like high risk behaviors. And if I wasn't, you know, safe and in a good spot mentally myself, that would have been really, really, really tough. And so I usually don't, I used to like advertise that a lot, like, yeah, I want to go into this because I had an eating disorder. And Dr. P, a lot of my mentors were like, no, don't, like tone that down, like tell them like you want to go in this field because you're qualified and you know what you're doing. And then say like, yeah, I also have personal experience and that's helped me, like that's informed this, but it's not about my personal experience. That's not my qualification. My qualification is all this work that I've done past that. And so, I mean, it is kind of weird in some ways being in Boise. I was treated by a lot of my colleagues actually. So therapists, dietitian, doctors, like they're all my colleagues now. And my eating disorder was when I was like 11 to 16. So I was quite a bit younger, but it was kind of weird going back into that realm and being like, oh yeah, you're my dietitian and now you're my colleague, or you're my doctor, now you're my colleague, and we're sharing clients together. And so I actually gave a presentation in my consult group about that, about going from like patient to professional and how that transition happened. And I needed time and I needed distance and space. And it took me a long time. Actually, my dietitian, the time that's not my colleague, she told me, she was like, I was really hesitant when I heard you were back in Boise and you were back like treating eating disorders. And she's like, you had to win my trust. And I'm like, fair enough. I was hell to work with back in the day. So I understand that, but it's a lot to navigate, and ethics is a lot to navigate too. Yeah, good question. Yeah.
I imagine it would be really hard to work, especially with children and families, to not take that home with you or to want to like hurt someone for some of the things that you might see. And I imagine that maybe doing something like research where you have to kind of get some objective perspective on things would be helpful. Do you use that? Can you, like, do you publish case studies or do anything in addition to the counseling, or how do you navigate that?
Yeah, so I actually still work with Dr. P doing research with Nicole and Lacey in here. So I still do like research just to get a different perspective and get a little bit of a break from just being like in cases all the time. And I think that is helpful. It's interesting though, like similar to like seeing a medical doctor, like maybe where there's things like I'm like, oh, this is really uncomfortable. And I hear this all day long. Like, this is not a big deal. I think that happens in counseling too, where remember like the first suicidal person I worked with, I was like, oh no. And now like I talk to 80% of my clients are suicidal every single day. And so there's not this like, oh, you're suicidal. It's like, oh yeah, you're suicidal. And let's work with that. So I really give DBT therapy a lot of credit. It taught me how to navigate all of that. And so rather than, dealing with someone that's suicidal and not knowing what to do, I'm like, okay, this is exactly what I do. And I have confidence in that DBT works. So I'm going to just go through these steps. And it's more like a math problem. In some ways, like, I mean, it's still very human, but it's also very much like a math problem. And so I think that helps a lot with burnout and disconnecting from that. And just, I think with time, it becomes a lot easier to disconnect. And I do DBT myself. Like I practice DBT skills every day. And there's a DBT skill called the effectiveness skill, which is just focusing on what works. And for me, getting really integrated and just really enmeshed in my client's work, that's not helpful for me, because then the next person comes in the next hour, and if I'm still worried about like Lisa over here and her suicidality, then I can't treat John and his eating disorder. And so focusing on what works for me is just being like, oh, okay, that was that hour. Like I can't do that anymore. I'm on my next hour. Like I'm going to give this person my all now. So it does, like with time, it becomes easier to deal with, I would say. And it's hard. I mean, COVID last year, I lost 3 patients to suicide, and yeah, it was devastating. It was really tough. And I mean, one of them like really, really, really hit me. And yeah, it was hard to like get back to work. I took some time off with that one. And yeah, it was hard. And I think that's why we do this work, is to be able to find, to be be able to find meaning and purpose in some of these really tough things. And that just informed more of the work that I do with the other people I work with. Yeah, it's hard. I mean, you have to take care of yourself in this field. This is not an easy field, and especially with COVID and especially with the growing need. I mean, I don't know a single colleague that specializes, or not even, I don't know a single colleague that's a therapist, period, that has openings right now. And so you will never, if you go into psychology and anything in this realm, you will never have to, I mean, I promise you, like, even with the world changing, you will never look for work. You will never be like trying to get a job. You'll never be like pedaling to get clients. Like it's your biggest challenge you'll face is not working too much. Your biggest challenge you'll face is setting boundaries and taking care of yourself. And that's, I mean, by far my number one challenge is just not working too much. And probably the hardest thing I deal with right now is saying no to people. That's probably the most difficult thing of my job, is being able to sending people away. I mean, I get referrals from people that are like, we really, really need to get our kid in. She's 13, she has anorexia, she's in the hospital. And I'm like, I'm so sorry, like my schedule's full. I really can't, I can't take your kid. I can't come in at 8 a.m. or I have to take care of myself because I can't help my other clients. I can't help myself. I can't help my family if I'm not in a good spot myself. And so it's tough. It is tough, but it does come more so with time. And yeah, but yeah, I won't lie. That's tough. That's really tough.
Would you say that there's a lot of overlap with your clients who see you outpatient and like other inpatient facilities like Lifeways and Pathways, that kind of thing? Like, do they kind of circulate, or would you say that you have like a more specific clientele?
Totally. No, best friends. In fact, I work with Intermountain and Cottonwood all the time. Cell phone, texting basis. I mostly work with like residential eating disorder treatment centers. So there's a medical doctor here that because the tricky thing with like Cottonwood, Intermountain, Lifeways, they don't typically take people with eating disorders. So if my clients are suicidal and are also medically compromised due to their eating disorder, then Cottonwood typically won't take them, or one of the psychiatric inpatient facilities here won't take them. And so there's a medical doctor here that specializes in eating disorders. So he usually will help me get them into St. Luke's. And they have a little bit of a protocol there, and then we'll try to get them into a residential facility. There's nothing in Idaho. They usually go to Salt Lake, Seattle, Portland, Texas. I've got someone in Chicago right now. I've got somebody in Portland. I've got someone in Salt Lake. I've got someone in Dallas. They're just kind of across the US. So yeah, so they'll typically go to a residential facility. And that I would say like the work that I do, the population I work with is unique in that case. I mean, if you're just doing like general anxiety counseling, or if you're doing like play therapy with younger kids or family therapy, you probably won't have people going in and out of the hospital or in and out of residential treatment centers. I really specialize in treating the most acute cases. That's what DPT is about. It's high acuity, high risk. And so I would say even my colleagues that treat eating disorders, I tend to see the highest risk ones. And so I have colleagues that treat eating disorders that don't even, they're not sending people to residential treatment often, but that's also unfortunately, the dealing with teens, because they are so much more medically compromised. They're so much more medically fragile, especially dealing with 9-year-olds. Like they just don't have a lot of wiggle room until they're really medically compromised. Yeah, I think it's, yeah.
How do you decipher one patient to another to take on?
Yeah, so my specialty is really like I created kind of the ideal, like what I'm trained in and what that works with. And so I do DBT therapy, eating disorder, suicide prevention. I don't take adults anymore. And so when I get a call for somebody that is suicidal, has an eating disorder, and is also an athlete, then I'm like, yep, that is like the perfect fit for me. I work with teen boys. So I specialize in like men and boys. And so like I had a call for somebody in his 60s that's a male retired athlete. And I'm like, okay, well, you're not under 18, but also like you are still part of that specialty. So I try to find as much overlap in those specialties. I also do OCD. And so that works really well with radically open DBT, RODBT. And so I tend to take that like grouping. So if I get a call for someone that's like 25 with bulimia, I'll probably refer them out to a colleague. So even in the specialty of eating disorders, there are subspecialties. So my like subspecialty in eating disorders is suicide prevention, athletes, and males. So that's really and then like OCD and like over control. So like chronic depression, OCD, and anorexia, which you often see together in a cluster. So anything in that group I tend to take, and then anything outside of that I try to refer out. And all of my colleagues, we share a lot of clients, we work really closely together, so it's not uncommon for me to do an intake with someone and say, hey, actually, my colleague is a better fit for you. I'm going to call them and see if they can get you in instead. So we do a lot of communication. In fact, the amount of like collaboration that I do with my colleagues is, I think that was a big surprise. I didn't realize how much collaboration I would do with medical doctors, dietitians, other therapists, but it's like multiple times a day. I'm like texting them, seeing if they can get someone in or if they can meet with this person or whatever. So it's a lot of collaboration. More like a liaison than anything sometimes. Yeah, thanks.
What do you choose DBT over CBT?
Yeah, so DBT is a form of CBT, and I liked that it was evidence-based for personality disorders. So I was at the time in grad school too, trying to find my niche inside of eating disorders, because eating disorders it's specialized, but it's also still pretty broad. And so I mean, you can get such a span of people with eating disorders. You can get a 9-year-old with an eating disorder, and you can get a 65-year-old with an eating disorder, and someone with binge eating disorder, and someone with anorexia. And those cases are going to be really, really different. And so I wanted to find just another specialty in that, and I wanted to have a theory that was like backing me up in that. And so in Spokane, they had this amazing IOP for DBT, and I thought like, awesome, this is great, because DBT really made sense to me because it was highly skills based, and CBT just seemed a little bit too broad. And so this is really opinionated, but the field of theory is very like, and field of like healthcare, everything, it's very business oriented. And so CBT has become a little bit more business oriented and is creating more like specialties within CBT now. In the past, it was very much like, this is CBT, it's really broad, and you just like, try to deal with like work with this with all of your clients. But now it's become a little bit more like branched out. So they have like CBT emotion focused, or they have like CBT for or for sleep, or CBT for veterans or whatever. So now they've like created more specialty because I think they saw so many people going over, honestly, but that was my opinion. Yeah, so DBT I think made a lot of sense. I also think DBT is it's my backbone as a clinician. If I didn't have it, I think I would feel really lost just in like dealing with those really tough cases. And so I think you have to have some type of like, at the end of the day, I'm turning to this. Like I still use, I use acceptance and commitment therapy. I use CBT. I use existential therapy. I use ERP, and DBT is like home base, so that especially when you have someone coming in with like multiple things and like total crisis, I know that I can kind of find calm and like, let's just go to DBT. Let's just do that. Yeah. And I think a lot of younger clinicians too, they tend to find that like subspecialty just so that they can kind of find their way, so they're not dealing with like the whole swath of cases. Yeah.
So from my understanding, suicide prevention isn't very common with therapists.
Mhm.
Where and why did you get that training?
Yeah, so as a grad student, when I did research, so actually with Dr. G here, I researched men's attitudes towards help seeking. And then we started doing suicide research, which was really cool. We got like a grant or some funding opportunity. So we did suicide in homeless populations here in Boise. So that just piqued more interest to me. And so actually I had an advisor in grad school, and I went in day one, I was like, I want to treat eating disorders. That is all I want to do. I only want to do eating disorders. And she told me, she was like, don't pigeonhole yourself. Not at this point in your career. Like you might love eating disorders now, but 5 years from now, 10 years from now, you might get a position in another related field, and you might really want to take that, or you might get really burnt out and want to switch fields. So try to like at least add 1 or 2 more things. And so as part of my graduate assistantship, I was doing research with a professor at UW that was doing suicidology and how irritability impacted suicide rates. And so I was like, sweet, that's perfect for me. So I kind of created that other specialty and then added personality disorders to that as well. But especially in eating disorders, I mean, there's a high rate of suicide. People with anorexia are 11 times more likely to end their lives. And so it was a good fit. So I needed that training. And then I think especially in the Treasure Valley, there wasn't anybody that was doing suicide prevention and eating disorders. So there was just a need for that added care. Yeah, I see you have an eyes page. Yeah, so that's great. I think suicide prevention work is very needed, and I think what's cool too about the field, especially with like a master's degree in counseling or clinical psych, like there's so much option of what you can do. I mean, you can go into like traditional counseling, or you can do more like crisis intervention stuff, which is what I was doing in the Spokane jail. And it was really fun. Like I really enjoyed it. They had opportunities to work with like the police department. They had opportunities to work with like in schools and just doing like assessment and crisis intervention, which is really cool and really needed. And I think we're seeing more of that too. I mean, at that time when I was in Spokane, I think the fire department hired like 15 mental health counselors just to do suicide prevention work and just to do like crisis intervention, which is awesome. And yeah, I think that this work, like I love being a therapist. It's such a passion of mine, but I don't think I want to do like counseling like this for the rest of my life. I'm sure in a couple of years I'll want to switch to more like admin or more just like crisis intervention, just to kind of switch it up so it's not like, because it can feel very monotonous sometimes, like just a cycle, like yeah, I grab my client, we sit down, we talk for an hour, and then I do it again. And so I think doing that for 30 years would be just kind of a lot, but I can totally see myself just switching into like crisis intervention for a little bit. And I think Craig Wansina, he's working.
Yeah, he's coming to class.
Oh, very cool. Oh, well then I won't spoil it, but
Greg's awesome. I've had him.
oh, cool. Yeah, very cool. Yeah, so I think he's a good example of like just other opportunities that you have in this field too.
Is there anything you'd recommend doing in graduate school to kind of ease your transition into the workforce?
Yes. Probably number one, setting boundaries. I think as a student, it's really tough with like finding the hours, because like you have assignments that are just due at random times, and you have like so much that just kind of like cascades all at once, where the workforce is very different. It's much more like gradual. Whereas like you might have weeks in school, probably not your senior year, but like weeks where you don't have a lot to do, and then weeks where it's like just chaos. And so I think just really setting boundaries with yourself and finding times, like, you know, doing homework from 6 to 8 p.m. every night or something like that. So you have a little bit more of a routine. Really working on your self-care. I know like everyone, I would roll my eyes when like everyone would come into our classes and talk about self-care. And I'm like, oh yeah, cool, great, whatever. And I always just thought like self-care is just like, yeah, like taking baths or like going for walks. But like to me, self-care is like getting good sleep and flossing my teeth and wearing my retainer at night and taking Advil before my headache gets really bad, and like things like that that are really like elementary, but things that really do like make a difference, taking care of yourself, especially like just getting older, like aging. Like I'm not super old yet, but there's just things where I'm like, oh, like I can't stay up super late and do this assignment or like get this paper written for someone or whatever. Like not paper, I write like a lot of letters, like much as for animals or insurance letters or whatever, like really setting those firm boundaries. Like I only work from this time to this time. I'm not going to check my email after this time or whatever. I think that's really helpful. Yeah, because it is a little bit of a transition. And actually it's a lot of a transition.
That topic, I was gonna ask advice for how to set boundaries and how to go about it.
Yeah. So especially when I first got into this field, I was so ambitious. I had so much energy and I just wanted to take on every project. I was just like, give me anything and everything and I'm willing to do it. And as an intern, I got like so overworked. And unfortunately that happens with a lot of internships that are like, sweet, free labor, like great. So as an intern, I got actually really, really burnt out. And I was working with a homeless population that was suicidal and had personality disorders. And that was really tough. And so probably the biggest thing I needed to learn was how to tell my supervisor no, and to be able to like swallow my pride that I like couldn't do everything. I couldn't see this many clients a day as an intern, especially, but even just as a therapist as a whole, and looking at like longevity in my career. Because I think that especially that like athlete mentality that's just like, you can do all of it now, like push through, keep going. But really like what I want for my career for 30 years, because I don't want to burn out within, 5 years of being a clinician, because I want to take on everything and do everything now. And so I really had to prioritize what mattered most to me. And so for me, like I do acceptance and commitment therapy as well. Acceptance and commitment therapy is about like finding your values and integrating in your values. So finding like the dissonance between your lived values and your ideal values. So I do the work that I teach my clients, right? So I went through like, what are my ideal values? How do I really want to live my life? And where am I living my life now? And what do I need to take off? It's okay not to do certain things. And honestly, I think that becoming like a specialized provider means not doing everything. It means like I don't need this certain thing. I don't need this certain thing. Like this is what a specialist is going to do. Yeah, that was hard though. I think it took a lot of pride or like swallowing my pride, I guess, humility to be able to like tell my supervisor, like, look, I'm not going to work 12 hours as an intern a day. Like, I just can't do that. I think that what makes it tough in healthcare in particular is that there's such a, like, for me, working that big day isn't like necessarily, it's not about money. It's about like helping somebody that really needs help. And so it's tough to be like, oh, you're suicidal. I can't help you right now. Here's the resources to call, and trusting that there's other people that are passionate out there that are also going to help pick up the slack too. But that was a real tough thing to be able to like set boundaries with somebody that was really suffering in that moment, because if I'm not in a good spot, I can't be there for them, and it is doing harm to your clients. Yeah, I'll give you 1 second. I have my mentee actually at the time, so she in my grad program, you would mentor a student that was a year younger than you. And she, same thing, wanted to work with eating disorders, had personal history with an eating disorder, really, really passionate, really excited. And she actually, 2 months before she graduated, quit the program because she was too burnt out. She's having panic attacks every day, was getting really suicidal and just couldn't do it. And I was really proud of her for setting that boundary with herself. But I think that was like a real like gut check for me too, to be like, oh shoot, like I've got to take care of myself, and that I'm my like greatest asset in this work, and I have to make sure that it's really taken care of. So I could talk like for hours and hours on this. Thank you for that question, because I could just go off on that. But yeah.
So what kind of was it more activity-based and hands-on during your master's program, or is it still kind of just assignments and stuff? I'm not really sure what happened.
Yeah. So the first year, so my program in the state of Washington, they do like 2-year programs. In Idaho, Utah, a lot of, trying to think, like Wyoming, I think their programs are like 3 years long. And so ours was an accelerated program, which means so the first 6 months we had like 8 hours of class a day, and it was just like, yeah, some hands-on stuff, but a lot of like reading and learning, tons of reading. Grad school is pretty much just reading textbooks. That was the biggest shift for me from undergrad to grad school, was just how much we had to read. And so most of the textbooks, like in undergrad, I didn't really read most of my textbooks. In fact, I didn't even buy them some of my semesters. Grad school, like you read like a chapter a night. So a lot of reading. And then we started a practicum and preceptorship our second semester. And so we had school like 6 hours a day, and then did like 2 to 4 hours a day at a site. So that was when I was at the jail and I was at the state hospital. And then you start your internship. And so the last, like that summer, so we had classes through the summer, but that summer and the last year I did like 4 hours of class a day, and then was at my internship the rest of the day. I think Boise State does it to where you're like in class the first year, and you'll do like role playing and stuff, and that's something you just have to get comfortable with. Like it's awkward and it's weird, but you basically do a bunch of free therapy for your classmates and vice versa. And you get really comfortable getting videotaped and doing transcripts of your therapy sessions and all that. But it's a little bit more hands-on. But I would say like year one, it's a lot of reading and a lot of just like cognitive work. And then Boise State year 2 is like a practicum, and then year 3 is an internship site. And then there is like a board exam. So I had to take 2 board exams before graduation in order to get my license. There's a CPCE, which was weird. And then there was the NCE, which is just on like counseling techniques. And so you had to pass the CPCE to be able to take the NCE, and then pass the NCE to get your license. So then the NCE is like a big high stakes 4-hour licensure exam. And I think like Boise State, you take it like the fall of your 3rd year. And then to become a certified eating disorder specialist, I had to take another board exam. So a lot of these like certifications and licenses you have to take, you have to have like supervision and board exams is the big part of it. So you have to get supervised by another therapist, take a board exam, supervised by another therapist, take a board exam. And then in the state of Idaho, so when you graduate with your master's degree, you become an LPC, so licensed professional counselor. And in order to become an LCPC, you have to take another board exam, be supervised for 2 years or for 2,000 hours, and then take that exam again, and then you can get an LCPC and go on your way. But they want to make sure that like there's a lot of supervision in this field. There's a lot of sitting in on sessions, watching other therapists, talking to other therapists, and all of that, which I think is so good. I'm a big fan of that. I know this can be a lot. It's really hard to like take the last 7 years of practice and kind of combine it into one. There's a lot, and I think there's really, you don't need to know where to, well, I'll give an analogy. So I am getting a therapy dog in June. So I want to train this dog to like be at work with me and to be there with my clients, because I think it's just awesome. My mentor has a therapy dog, and sometimes I will borrow her dog in my sessions for my clients, especially like my 10-year-old clients that come in and they're so anxious and they don't know what to talk about. And really, a 10-year-old can't really sit and talk for an hour and just tell you about their day. Like their brain just isn't really operating on that level. And so the dog is just so awesome. And sometimes these clients, like, they hate me. They hate coming to therapy. Like they're just, mad to be there. And the dog, like they'll just lay with the dog and snuggle her. It's the best thing ever. So I'm currently like in the depths of learning all of dog training things. And really it's kind of cool. It's like basic behaviorism, really training dog. It's really awesome, but basically just reinforcing what you want and not reinforcing what you don't want. And anyways, in this book that I'm reading, it talks about how the first 12 months of a dog's life are the most important, which is like, synapses, use it or lose it type of situation. And that how you want to teach them as much as you can in that first year of their life. But you don't have to teach them everything they need to know in the first year of their life, because there's no way to anticipate what a dog needs to know when it's 10 years old, or if you move houses and you have to train it to sleep in a different area of the house or whatever. But you just have to teach the dog how to learn in the first year of life. So you don't have to teach everything you need to know. You just need to teach it how to learn. And I think that that's very much like how this field works. Like this is healthcare to me, or this is like psychology to me. You don't need to know everything. You just need to know who to go to learn what you need to know. And so even as a therapist now, like there's so many things that I get where I'm like, I have no idea how to deal with this. Or a client will come in and tell me something and I'm like, like my face is calm, but inside I'm like, what? Like I've got no tools to deal with this. And so there's no way to anticipate what I'm going to be dealing with as a clinician. I just need to know who to turn to and what type of support, or who I can get supervision for, who I can get consultation from. And so I think having just that good network of providers and people that I know and colleagues. So I have Dr. P that I can talk to about like research stuff, and I have medical doctors that I can talk to about the medical side of things, and I have other clinicians, other therapists I can talk to about the therapy side of things. So I do a lot of supervision and I do a lot of consultation. I try to do at least 1 hour of supervision a week with another colleague, even if that's just me talking to my close colleague and just saying, like, yeah, I've got a client dealing with this. What would you do in that situation? Because we can't do this on our own. And we become really biased as providers. I mean, I'm really biased with DBT. I think DBT is like just the cat's meow. And my other colleagues are like, no, like, emotion focused family therapy is where it's at. And so I can talk to them and get a different perspective. And that's really, really helpful. So we have to constantly be checking our biases, especially just as far as like multicultural purposes. I mean, how am I treating this client versus this client? Or what are my own biases with this client or with this client? Or am I really burnt out with this client and I'm treating them a certain way? And so just building a network is probably the most important thing that I would recommend for somebody going to grad school, somebody not going to grad school. In addiction therapy, we talk about like connection is cure, community is cure, and anything you're doing in the field of psychology is mostly going to be really difficult. So you need connection, you need community. And if you do that, then it can be the most beautiful, wonderful thing ever. And I think having a job and having a career path that is full of purpose and passion is the best gift. Because I mean, yes, work is work. I'm not like Monday morning, woohoo, like I get to go to work. Actually, today I was pretty pumped. But work is still work, but I really, really love my work and I really enjoy the work I do. And there's a lot of days where I'm like, wow, I can't believe I get paid to do this. Like, this is so awesome. And so I think that if you can do it correctly and if you can take care of yourselves, and this is like, it doesn't get any better than this, honestly, which is really, really, really cool. Does anyone have questions about like private practice versus working in an agency? I know we have like 15 more minutes. Or like any particular questions like within the field. I mean, there were options to like go into the military right after. That was something I was looking into. I think like the Air Force Base in Great Falls, Montana was recruiting from our program. They would pay off your student loans if you want to work for them. That was probably a pretty tough job, but honestly super cool. I have a lot of friends, I have a couple friends that work at the VA. There's a lot of options with that. There is going into private practice, there's working in agencies or working in hospitals. There's any questions about like specific things in like post-grad life or even without a master's degree? Any questions in like bachelor's degree? Yeah.
I want to hear more about the private practice and why you decided to open that up versus being an agency or whatnot.
Yeah. So Idaho has a really good market for private practitioners. We don't have a lot of group practices. In fact, there's really not many at all. There's more that have happened since COVID, but it is very much a private run market. So I think most people it is recommended to work at an agency for the first couple of years of your practice, just so that you don't have to like outsource to get supervision and outsource to like billing and learn the business side of it. Because the business side of it is actually a lot of work. And that's really the part of my job that I hate, because I am not good at scheduling or billing or anything like that. And you can't outsource all that. And Nicole is actually helping me do a lot of that stuff too now, which is great. But I had a really great mentor that was willing to just mentor me through it. So Christy Shohead, she owns a building. And so I was able to just like rent from her. I lost money for the first 6 months of it because I just didn't know how to bill people and didn't know how to like run a business. So my business was in shambles. Still, like I call my accountant almost every day because I don't understand a lot of things about it. But I really wanted to do this work, and there were no options. As far as eating disorders in Boise, when I graduated from grad school, I could work at Intermountain Hospital, which doesn't accept eating disorders, but works with suicide prevention. I could work, Cottonwood wasn't even a hospital at that time. So really Intermountain was the only option I had to work like with eating disorders in Idaho. And I knew I wanted to be back in Idaho because I had such a good network here, my family's here and all of that. So if I would have stayed in Washington, I probably would have worked at a treatment center. And so I was actually I applied at the treatment center in Seattle and one that I worked in LA, but it was too difficult to transfer back to get into California with that. And I just really wanted to be back in Boise. So private practice made the most sense for me at that time in Boise, but I had to lose money for a while and learn the business side of things. And I wouldn't recommend it unless you have like a really solid mentor that is like telling you how to do everything, because it's tough. That's why most people don't go directly into private practice. But I think most clinicians end up in private practice at some point because you just have so much freedom. I mean, you're on your boss. You get to choose what hours you work, and you get to set your schedule. I mean, it's pretty awesome as far as that. You just have to do the business side of it, which is actually, it is kind of cool to do the business side of things too. It's just a lot of work that I'm not trained in doing. I think at this point, if I were to go back to school, I'd probably get an MBA than a PhD, because an MBA would probably make more sense with the type of work that I'm doing. Yeah.
Would you say becoming a counselor was like financially worth it? Obviously, like becoming a counselor, there's a bigger reason, but finances is part of it too. So would you say that it was worth it, or would you have to a different path? Especially since you said you struggled with the opening the private practice.
Yeah, that was a challenge. So now, yes, it is worth it. I think so. Money is so taboo to talk about. It's so funny talking about money. But working at an agency, well, I'll just give you like a broad. So if you in Seattle, so the job that I applied for in Seattle right out of grad school paid $80K a year and had benefits. So it was a good job. It was a tough job working in a residential treatment center, and about like 50, 60 hours a week is what, like it's a 40-hour week job that ends up being 50, 60 hours a week with really high risk clients. But I mean, that's, I think, pretty good. Idaho wages are way lower, much lower. If you go into school counseling, I don't think it's worth it. I think school counseling hires at like 43K a year with a master's degree, which just to me, I don't think it's that worth it. That was also why I was like really adamant on going to a program that funded at least part of my program. And actually, my program that I went to, they cut the funding my second year, so I did have to take out student loans halfway through my second year, which was a great plot twist. But it was, I mean, it was fine. I was okay with that because I was able to get like in-state tuition at that point. But I don't personally think that it's worth it to go to a really big fancy school and go really a lot into debt to work this job. I think that with a master's degree, I think you can expect to make anything between like 50 to 250K a year, depending on where you're at. I mean, you can get into admin positions and make really good money. You tend to make more money in private practice, but you can also make way less money because if you're working 10 hours a week or whatever, but you can really, I think that's why a lot of clinicians end up going into private practice because they realize like, oh, I'm working at the center and I'm billing. So like Blue Cross of Idaho, they reimburse $120 an hour. So I'm billing Blue Cross $120 an hour, but my agency is only paying me $40 an hour. So if I do all the business stuff and I can do everything on the back end, then I can keep that entire check. So that's why people ultimately go into private practice. But if you're me, the first 6 months of private practice, I'm like 22 years old, like, oh, I don't know how to do this. Like, oh, and then I'm like 6 months later, I'm like, oh, you only have 6 months to bill in insurance. Whoops, didn't bill it. So I just worked for free that hour. And like, you're only getting billed for the hours you're seeing clients. So if somebody doesn't show up, you just don't get paid. Whereas in an agency, they're like, you're getting paid salary, you're getting paid on the hours. So you are dependent on people showing up, sitting in the chair and getting paid for that time. But COVID, I like have not had cancellations. Sometimes we'll get cancellations, but for the most part, like people are there at their therapy appointments. So it can be really lucrative. It can also be not very lucrative. But I think that for the most part, most jobs, if you're going to a conservative program like Boise State, then yes, it is worth it. Yeah. But that's, yeah, it's so dependent. But I would say for the most part, yes. We probably have time for like 1 or 2 more questions. Yeah.
How long did it take for you to get your private practice up and running?
Yeah, so when I got into the Valley, there was nobody that was doing suicide prevention and eating disorders. So I was full almost immediately. I was full within a month, and I didn't realize, I just had no idea how to run a business. And looking back, like probably shouldn't have just started a business at 22. But I thought like working 40 hours a week was seeing 40 clients a week. Like, yeah, great. So I took on like a ton of clients, and I was working like 70 hours a week because usually for every hour you're seeing a client, you're doing another hour of work. I had no idea, like this is just me not knowing how to run a business. And so that was like, it was chaotic. It probably took me about 2 years to recover from that, to get my practice back to a place where I was like, oh, this is like, okay, this is like what working full time to me means. And this is what, like, this is how I do billing. And this is how like my practice is running really smoothly. So the first 2 years were really, really chaotic. And it was a big investment of just like time, money, mental headspace. I didn't really do much the first 2 years of my practice as far as like friends, anything else, because it was just chaos. And then after that, now I just love it. It's awesome. Awesome. So it did take a big investment of time and energy, but now I know I could never go and work for an agency now because it's just awesome. I mean, today I just like moved all my clients, and I see 2 clients today at 5 and 6 p.m. So awesome, like pretty chill day for me. So, and then tomorrow I have a big day. Wednesday I'm like working a half day, so like I can just kind of choose that. So that part's pretty great. So yeah, if you are interested in business, like doing a private practice, you can. I mean, I would say 50% business, 50% psychology. So it's kind of fun too because I get a little bit of a break from like client work, psychology, all of that. And there's just a lot of options in this too. I mean, you can go into healthcare admin, you can go into running a clinic. I mean, St. Luke's and St. Al, they're like hiring like wild right now for people with masters in counseling to run clinics because you have really good person skills, you have really good communication skills, so you have a really good skill set that's marketable and other opportunities. Yeah. You can also work for insurance companies. So I have a lot of friends from grad school actually that like COVID, it just got too heavy for them. They left the agencies they were working at, and they started working for utilization reviews for insurance companies. And honestly, like it's kind of a good gig. Like you usually get paid more than an agency would pay you, and you're not doing client work, you're just reviewing case files. and deeming like what care they need. So there's a lot of cool positions you can have in this field. Yeah. Yeah, maybe like one more question. Final thoughts?
For someone who wants to transition into private practice, what jobs would you recommend doing before so you get kind of like the best of both worlds, both practicing and business?
Yeah, I would recommend working in a hospital or at like a residential eating disorder treatment center or like an intensive field, because like, it's part of the reason why I took a preceptorship at the jail, because I didn't want to be surprised with anything I was going through. And so one of the first inmates I worked with had 5 murder charges, and I was like, okay, sweet, like I can handle this. And I got to see like literally every single diagnosis in the jail, which is really sad and unfortunate. And then working at the state hospital, same thing. And so in private practice, I mean, it's scary because like I don't have anyone that has my back. I mean, I have a good network of other providers, but I don't have like a massive, billion-dollar healthcare system that I'm like turning to say like, hey, can you help me out with this? So working in a position where you will see every diagnosis, you will see chaos, you will see crisis, so that you are not panicking, working by yourself. And then as far as the business side of things, I really don't learn that anymore, to be honest. Like maybe business school, maybe, but more so like I learned that through my mentor. And so I paid her for the first while. I actually paid her for lessons in business, and she like taught me how to run a practice. And so I like was not only paying her for supervision, because you have to get supervised for 2 years out of school. So I was paying her for supervision, but I was also paying her to teach me how to build, teach me how to do all those things. Probably why I lost so much money because I wasn't really enough. So yeah. So mentorship comes back down to mentorship, I think.
Thank you.
Yeah, that's everything. Feel free to email me. I can put my email on the board and email me